Dear colleagues, ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to welcome you here in this wonderful evening where we are here together to share knowledge and exchange expertise in a very important topic. And in fact, this is a collaborative medical education in collaboration with the Saudi Society for Family and Community Medicine and GSK Company. So I would like to thank both organizations for providing us with this opportunity to be together here today, inshallah. So as you know, ladies and gentlemen, our topic will be respiratory syncytial virus and the burden of the disease in older adults and its prevention. And before we start, I would like just to pave the way and say a statement, in fact, just to let you know that our healthcare system in the Kingdom of Saudi Arabia is getting transformed. And this transformation has for an important reason is to reinforce the prevention. Long time ago, we have been engaged as clinicians and as medical professionals in treating the disease and treating the complication of the disease and rehabilitating those patients who have been a victim for certain disease. But now we have changed our perspective and our thought towards preventive medicine. So now we are moving from intervention to prevention, from disease to health, from illness to wellness. And this is, ladies and gentlemen, just to improve the health status of our community and to reduce the financial burden on our healthcare system. And as you know, ladies and gentlemen, nowadays we have a new concept which has been added to our healthcare system, which is a value-based healthcare. Value-based healthcare means providing high quality of service in a patient safety, multidisciplinary team approach, in patient-centric approach, we're using guidelines and then having the proper clinical outcome that we would like in terms of controlling the disease or preventing the disease minus the cost. So cost effectiveness is one of the measurable items in our new healthcare system. And it has been identified that primary healthcare and family medicine are the specialty that fit perfectly in this kind of concept. Why? Because the easy accessibility, the holistic approach, the cost effectiveness, and maintaining the continuity of care with our patient throughout the spectrum of their life. So the best part of our scope as a family physicians and a primary care physician is preventive services. And when we talk about preventions, there is always comes to our mind the vaccinations against vaccine preventable disease. And that's why this is one of the very important tasks that we all have been privileged as primary care physicians, in contrast to our colleagues in different subspecialty. So they refer their patients all the time to us, to handle this kind of prevention. So we should be very proud and we should be accountable, we should be responsible, and we should do the best state of art that we can provide our patient with. So today we're going to talk about this. And of course, an important statement also I would like to mention that the acute lower respiratory tract infection is a major healthcare, a major problems in our community in the Kingdom of Saudi Arabia. And as you remember, in 2013, it has been estimated that the prevalence of these upper respiratory tract infections affected more than 5 million of our population, which is about 15% of our total populations. And all the epidemiological studies indicated that the viruses were responsible for this kind of upper respiratory tract infections. And this is for two important reasons with a high prevalence in our society in the kingdom. Why? Because of the mobility of the large number of the foreign workers and the gathering of millions of people who are Muslims for the pilgrims in Mecca during the Hajj and Umrah season. So we have been privileged to host this kind of massive gathering, so that's why we have been encountering this kind of viral infection that spread. And of course, as we know that severe acute respiratory infection caused by different pathogens, and we have learned by our experience during the COVID pandemic that we have confronted a very devastating respiratory disease that has a lot of consequences. But alhamdulillah, our country has been saved by Allah subhanahu wa ta'ala first, and then by the right decision which has been taken right on time to preserve the human health rather than to preserve the economy. And of course, during this era till today, we have been confronted with a lot of respiratory tract infection during the season of changing season from winter to summer. And now we are confronted with coronaviruses, influenza A and B, and RSV viruses. And as we know that RSV viruses in adults usually we can say that it's a hidden annual epidemic. So for this, ladies and gentlemen, I would like to mention that these different types of upper respiratory tract infections are indistinguishable from each other. So that's why it constitutes a real challenge for us as a primary care physician to identify which one is which and what is the treatment. And of course, for the RSV, there is no specific treatment, so it's a symptomatic treatment, but we have a very important tool to prevent the disease by having the vaccination. So, ladies and gentlemen, today our objective here, we are going to talk about the burden of the RSV in elder adults and what are the symptoms that is very important for us to identify it and to differentiate it from the different upper respiratory tract infections, and what are the timing of infection incidents that we have to anticipate in order to predict when is the peak of the season of RSV, who are at risk of having this kind of disease, and how the spread of the infection take place, what are the measures to reduce the risk, and what is the vaccine which is available for the RSV. So for this, ladies and gentlemen, we have been privileged today to have our colleague, Dr. Rani Miliani. She is a consultant internal medicine and geriatric medicine, joint assistant professor of King Saud Abdulaziz University in Riyadh. She obtained American Board of Internal Medicine and Geriatric Medicine. She's the director of the Geriatric Medicine Fellowship of Ministry of National Guard Health Affairs in Riyadh. She's the head of the scientific committee of the Saudi Geriatric Associations. So we have been pleased to have you here with us, Dr. Ranim, and we are very privileged. And I'm very sure your session will be quite interesting for all of us as a primary care physician to learn from your expertise, with a special focus on your specialty of geriatric that hits exactly the target group that we would like to mention today, who are older adults that are subjected to this. Before that, ladies and gentlemen, I would like to highlight that we have housekeeping notes. To earn your CMEs, please register and clearly write your Saudi Commission for Health and Specialty registration number, and we try to put your questions in the Q&A box. And I think we have, before we start, so I would like to introduce myself. I'm Dr. Ashraf Amir. I'm a consultant in family medicine. I'm the vice president of the Saudi Society for Family and Community Medicine. I've been practicing for the past 30 years, and I've been privileged to be one of the workers in primary healthcare that serve our community and serve our nations with full capacity of expertise. We are going to have today Dr. Ranim Miliani, and we have another session tomorrow for Dr. Tarat Al-Misani, and then this will be followed by another session for Dr. Asim Abu Dair. And this is our disclaimer. So I'm not a GSK employee, and I have received a note from GSK. And ladies and gentlemen, I would like you to scan this QR code in order to get into the questions. We have a pre-test and post-test. So in order to identify your basic knowledge that you have it here today, so you can scan it and get into the pre-test, and then at the end we'll go for the post-test to learn how much we have gained and how much we have been privileged to learn from our speaker tonight. I'll give you 2 seconds, 30 seconds to scan the barcode, QR. So if you are ready now, we'll go for the first question. The first question is: respiratory syncytial virus infections may occur in upper respiratory tract, in the lower respiratory tract, in the lower digestive tract, in upper and lower respiratory tracts. So please put your answer, and then we'll be able to see the result later on. So the second question is: all of the following groups are at increased risk of severe illness due to respiratory syncytial virus, except older adults, especially those aged 60 years or old, healthy teenagers, people with a chronic heart or lung disease, immune-compromised people. Give you 30 seconds to answer it. And then the third question is true or false? After full recovery from RSV infections, most individuals cannot get reinfected. Is it true or false? Fourth questions is incidence rate ratio for RSV hospitalization in older adult with a COPD, chronic obstructive pulmonary disease, is compared to healthy individual. Is it 2.3 to 3.6, 3.5 to 13.4, 3.7 to 6.5, 4 to 7.6? The next one is incident rate ratio for RSV hospitalization older adults in congestive heart failure. Is it 2.3 to 3.6, 3.5 to 13.4, 3.7 to 6.5, 4 to 7.6 compared to healthy individuals? So with this, ladies and gentlemen, I would like you to preserve your answers, and then we will be able to highlight it at the end of the presentation. So with this, I would like to welcome again Dr. Ranin Manyani for being with us here. I would like to leave the floor for you, Dr. Thank you.
Assalamu alaikum jamian. Thank you, Dr. Ashraf, for the nice introduction. I can't agree more with every single word that you've mentioned in terms of prevention is the proper way to go right now, especially with the healthy aging and older adults. And we're currently promoting how to live longer and have a better quality of life with the older adults. And prevention is the way to go. So this presentation, I will share it from my end. So I'm going to end your presentation now. Um,
Go ahead.
بس I will go like this. Paired الآن.
Yes, we can see it, Dr. Ranin.
Okay. So this is my disclaimer, and I'm going to be talking about the RSV respiratory syncytial virus and the associated disease. And as well, I will go with the RSV and the relationship between the RSV and the cardiorespiratory conditions and other comorbidities. And what is the RSV itself? How do we diagnose, manage, and prevent the disease itself? So the RSV, in general, it's a virus that it's very contagious, and it's transmitted between an infected person to a healthy person, either by inhalation or a contact from from the infected person's respiratory secretions. And if anyone in the house is infected, it's easily to be spreaded by the secretions of the infected person. And the average of the patient or the person who's infected to infect other people is 1 to 3. And usually the RSV is seasonal, so you can see it in the northern hemisphere. If you look at the temperate zone, you can see the peak of the RSV virus usually in the between November to March, and the peak you can see over here that it's more in January, month of January, where the peak of the season is very high. And the RSV the epidemic of RSV can last up to 5 months. And if you look at the tropical zones, you can see that the peak is almost across the whole year, and it's mostly between the January and May where the peak of the virus is around these couple months. During the COVID-19, because of the pandemic, we've seen a disrupted pattern for the seasonality of the RSV, and it causes increase of the possibility of out of the season outbreaks for the RSV seasons. And last year, between 2022 and 2023, there was a rise in the viral respiratory diseases. They've observed it with increase in the circulations of the RSV with the influenza and other viruses during last year. So the RSV itself, diseases of all ages. You can see it in young adults, you can see it in older adults, you can see it in the children's. But if you look at the picture over here, you can see it's mostly in the extreme populations, where you can see it more in the infants and children's. because mostly by the age of 2 years, you can see that the RSV has infected almost every children's younger than 2 years old. And in the other end, the extreme end, the older adults, you can see that the RSV incidents are more in the older adults. And in between these two groups, it can still infect the younger like the older, the young age, and because the immune system or response to the RSV is the natural infection immune system, it's incomplete and shortly lived. So in that lifelong, you can see that the patient can be reinfected again with the same virus, which is the RSV, but it's morely infected in the higher risk population, which is the older adults. And the reason is we are saying they're more to get more infected of the RSV virus is because of the comorbidities and their immune system is weaker. So, what are the signs and symptoms of the RSV infections? It's like any other upper respiratory or viral respiratory infection where you can find a cold like symptoms, and it's usually mild symptoms. And the RSV in general usually can cause some runny nose, some fever, some cough, like any other respiratory pathogen. But the thing is, with the RSV, it might lead to some serious complications and poor outcomes. And if you look at the complications in terms of the lower respiratory tract infection, it can cause pneumonia. And if you look at the patients who have some COPD or asthma, it can cause some exacerbations of their disease, like asthma exacerbations or COPD exacerbation. And if other patients have some underlying cardiovascular diseases, they might have more complications of the cardiovascular disease. And those kind of complications in the older adult populations can lead them to a hospitalization and death. So the risk factors for severe RSV in older adults, specifically those population that are 60 years and above, and they're also increase in their age, you can see that they have more risk of comorbidities like heart failure, like diabetes, CKD, COPD. And their immune status has weakened with aging. Their response even to fight the infection is even weaker compared to younger adults. And usually people would think, I mean, the RSV probably is more, the incidence of RSV is more maybe in the pediatric population. But this is not the case. I mean, if you look over here, there is a study that where they looked or numbers of the incidence of RSV leading to hospitalization, and they compared it between the pediatric population or children with the older adults who are 65 year and above. And if you look over here, you can see that in children aged less than 5 years old, there was 58,000 hospitalization and 1.5 million outpatient visits and almost 500,000 of ED visits. And total death annually is around 100 to 500 deaths a year. Compared to the older adults, RSV was the major cause of hospitalization and mortality in older adults. And when they looked at the numbers of hospitalization, they found it's like 177,000 of hospitalization for older adults because of the RSV. And the outpatient ED numbers were underestimated because there is no usual or routine surveillance for the diagnosis of RSV in the outpatient and the emergency. And the total deaths was 14,000 deaths because of the RSV. So the incidence of the hospitalization and mortality due to the RSV is quite higher compared to the children. And over here, they were looking at the burden of RSV in the industrialized countries, and it's under-recognized. The prevalence is under-recognized. This is just a systematic review and meta-analysis to estimate the burden. And if they look at the older adults incidence with RSV, it was 1.6%, which is around 5 million cases of upper respiratory tract infection because of the RSV. And the hospitalizations were around 0.1, which is equal to almost 500,000 of hospitalization. And the in-hospital case fatality rate was 7%, which is around 33,000 deaths in the industrialized country. So the global RSV burden is underestimated. And the reasons why is that because of the routine lab confirmations of the RSV, specifically in the outpatient, is not widely established and not widely done in the outpatient practice and even in the emergency. And most of the studies that were done is mostly in the high income countries like North America, Europe, and Asia Pacific regions. So, and the other countries where there was no much data to look for the burden of the disease. So looking at the mortality and the morbidity in adults hospitalized with RSV. This is a retrospective cohort study of a hospitalized patient, and the mean age was 75 years. It was done in Hong Kong. And the number of patients included in the study populations were around 600 patients. And what they looked at that this population of almost 75 years old, 87% at least they had one or more comorbidities. And they found like 35% of this population they had chronic lung disease, and the rest were major systemic comorbidities like neurological conditions, renal disease, cardiovascular, kidney disease. So the majority of them, they have one comorbidity. The outcomes of that study, they found that the all-cause mortality, 9%, they had a high mortality within 30 days, 11% within 60 days of all-cause mortality. And their cause of death, almost all of them, like more than 50% of them, of this percentage were due to pneumonia. Some of them may had COPD exacerbations, and some of them they had a cardiovascular event, and some other medical conditions that were complicated by pneumonia and sepsis. And 11% of the patients who survived the RSV, they required ventilations, and almost more than 50% of them, of the patients who had the RSV, they required oxygen supplementation. And their actually mean durations of hospitalizations for the survivors of the RSV, they had 12 days of hospitalization. So definitely the RSV has caused severe lower respiratory complications in this population age of older adults, resulting in a respiratory failure and prolonged hospitalizations and a high mortality. And over here, this study actually, they looked or did a comparison between the complications of influenza, compared it to the RSV patients who had RSV in the United States. And if you look over here, you can see in the orange side, the right side, that the incidence of hospital utilization, respiratory outcomes, and survival and the post-hospitalization care were more higher, going toward more of the RSV complications, more than the influenza patients who had patients who had the influenza. And more patients actually had home health care, or they needed care at home from nursing care with the RSV patients. This is another study, global prospective study actually, where they looked at the rate of complications and mortality in adults who were hospitalized with the influenza compared to the RSV. And if you look definitely here, there is more incidence and percentage of patients who had more complications of the lower respiratory tract, and they had more bacterial superinfection. They had more cardiac complications, 31% compared to 24% in the influenza group. And they had more high mortality rate during the hospitalization with a 2.5, which is double the percentage of influenza patients. Looking at the long-term impact of RSV infection, and this is really what we really care about for the patients, older adults in the geriatrics population, or in our practice, looking at the long-term impact of any infection or any hospitalization. What they did look here is they looked at the functional status for older adults who are 60 years and above. And this population, these patients were hospitalized with RSV. So they looked at their function prior to the hospitalization, and then they looked at their discharge, and then they looked post-discharge, 6 months post-discharge of if they're living independently or they needed some help or assistance after discharge. So if you look at the figure, you can see that 40% of the patients in the study, they were almost living independently. That number decreased in discharge. 26% of them, they were patient living independently. And after discharge, 6 months post the discharge, they found like 30% of the population living independently. So definitely you can see there is a drop of the level of function of patients after discharge with RSV infection. And 80% of the patients reported an ongoing loss of their independence after 6 months of discharge. So definitely for an older adult, what we really care about is their independence, is for them to preserve their function even if they're 100 years old. Basically, what we're saying here that the long-term impact has definitely affected their function. Not only limited to their function of older adults, this adult patients hospitalized with RSV, they had 24% required professional home care. That they mean they were discharged with a home health care services. 26% they required readmission back within 3 months of post-discharge, and 33% mortality rate looking at 1 year after the admissions. And the overall associated with adverse effect because of the RSV, it affected the older adult, their productivity, that it affected their social and their activities of daily living where they usually enjoy. It affected also their relationship with others. It had a big toll on their emotional, physical, and cognitive function because of the hospitalization and complications, and even affected their sleep and probably because of the depression and their emotional effect because of the long-term impact of the RSV. This is a study to show you the impact of the functional and the also the quality of life. That's what we care about, the quality of life of older adults. They looked in this study 50 years and older with an RSV positive and compared it to patients who are RSV negative. And they looked at the short-term impact and the long-term impact by a health survey. And this study was actually done in Minnesota, United States between 2019 to 2020. And if you look at their physical health, it's definitely impacted in the short term and a long term. You can see that their impact for the short term, it was very significant, and it continued even after a long term, after 12 to 3 months of the infection. It continued to show also impact on their emotion. It continued to show impact on their lower energy and fatigue. It definitely impacted their social function. And this will definitely summarize that the RSV positive versus match RSV negative, it definitely in a short and long term affected their overall quality of life and made it worse. So what is the economic burden? We're talking about their quality of life, function, they're talking about the complications of the disease, but what about the healthcare system in general? Is there any impact? So the RSV causes a sizable burden on a healthcare system and socioeconomical cost. And if you look in this study, they looked retrospectively and looked at the case control database, and they looked at the utilization of the resources and the cost with patients who had an RSV. And if you look over here, they did put in the horizontal line from 18 years older up to more than 85 years of age, the healthcare cost for patients in purple with an RSV positive with a match control. And the total number of population that they looked at is around 11,000 patients. And if you can see, definitely there is a huge difference when you start looking at the cost of the healthcare expended on patients with RSV. There is a huge difference. In ages between 60s and 70s, you can see there is an increase of $12,000. In 70s and 80s, like around $20,000 and so on. So there's definitely significantly higher healthcare resources used than the control group age without the RSV infection. And there was a study recently that was published that did show that the RSV infection in US adults who age 60 years and above, on a one RSV season, the annual direct medical cost was estimated between 1.5 to $3 billion in that year. So now looking further, what are the relation between the RSV and cardiorespiratory conditions? If you look at this viral infection and the effect of the RSV or viral infection on the COPD, and we're going to look also at the asthma patient. On patients with the COPD, you can see there is more estimations of like there is more longer hospitalization. They will have more accelerated deterioration of their lung function. They will have greater hypoxemia, and they will have greater airway inflammations where they have more of an exacerbations of their COPD because of the increase of the eosinophils and the inflammations in their trachea and alveoli. Also, in the asthma, you can see there is definitely worsening of the asthma with increased hospital admissions, also enhanced responsiveness to allergens, and also there will be some altered antiviral immune response in asthmatics patients who has associated with asthma worsening with the patients who will have some viral infection. So an overall, what about that was an overall worsening of COPD asthma with any viral infection. But looking more deeply into focus RSV infection, there will definitely the RSV has been detected in 10% of these acute exacerbations of COPD. Looking in a prospective study, they found that the RSV is accounted in those hospitalized patients with a COPD. They had more of an 11% because of the RSV in these populations of COPD. In the asthma population who were hospitalized, they found that 70.2% it was because of the RSV infection. And among adults aged 18 years and old hospitalized with the RSV in the 12 countries, they found that 26% had COPD exacerbations and 30% has a COPD asthma exacerbation. So the RSV infection is that common in this subpopulation of COPD and asthma. So, what are the viruses? How common is the RSV, and what are the other viruses that was found in the COPD or acute COPD exacerbations? This is a systematic review of a pooled data for the prevalence of viruses in patients with exacerbations. And it was coming when this data is from 19 studies, and the number of patients that they looked at 1,700 patients. They found that the rhinoenterovirus was 16% and the influenza is 7%. And they found that the RSV actually is more the incidence of the influenza with a 9% prevalence. And on the right side figure, you can see that the looked at the incidence of the RSV in the upper respiratory airways and compared to the lower respiratory airways. And you can see that the RSV it's found more prevalent in the lower respiratory airway tract than the upper respiratory airway. And it's almost similar to the other viruses. So looking at the age in general, we talked about older adults. So what are the evidence behind that the RSV is more increases with age and certain comorbidities in the older adults? This is a large prospective study to show you how much is the association between hospitalized adults with RSV and age. And there was around 1,000 patients. And if you look at the incidence of RSV in hospitalized patients by age group and season, you can see that the incidence is more higher in the age group from 60 years and above. And it's more even higher when you go up with age. And the comorbidities that they found that there was incidence of an incidence rate ratio with asthma is 2.3 to 3.6. You can see the COPD, they had 3.5 to 13.4. And the coronary artery disease is 3.7 to 6.5. And chronic heart failure, they had incidence specifically with the patients 60 years and above from 4 to 7. And the diabetics from 2 to 6, the incidence ratio. And over this slide to show you also the underlying conditions that are more common with this population of older adults, you can see that there is a congestive heart failure is one of the common comorbidities, diabetes, COPD, which actually showed the 80% of the exacerbated patients with hospitalized, ischemic heart disease, asthma, dementia. We see as a geriatric in the inpatient, we see a lot of demented patients. So this is also a population that might have some incidence of as an underlying risk for viruses and any solid cancer patient. So over here, if you look at the complications of COPD, when we said that the accelerated decline in lung function, this is a prospective study. They looked at the relationship between the RSV detected pattern and the FEV decline. And if you look at this figure, you can see that the FEV is in the vertical axis, vertical line. And you can see per year and by 2 years, patients who had a high RSV positive test or a chronic infection were had a higher or faster decline in their function, in the lung function test, compared to the patients who had low RSV or they did not have an RSV. And they had actually more higher inflammatory parameters in patients with stable COPD who had the RSV positive. So in summary, the COPD and asthma patients in older adults are more higher risk or increase the risk of having a severe RSV disease. High proportions of older adults hospitalized with RSV, they had experienced COPD and asthma exacerbation. Persistent RSV infection is associated with decline in lung function and higher airway inflammation in patients with COPD population. So what is the correlation between the now with the respiratory infections, viruses, and the cardiovascular disease? Why we're saying cardiovascular disease is really can cause some complications whenever you get the RSV virus or any viruses. What are the mechanism and correlation between both? So the viral respiratory infection may exacerbate the cardiovascular by a mechanism. So if you look at this image, you can see that this patient, or if you imagine that this patient had a chronic cardiovascular disease, so this patient, he will definitely is a higher risk of upper respiratory infection. And this is going to put him into a hospitalization and increase high mortality and morbidity. And the mechanism is that because of the systematic inflammation due to the viral infection. And if you look at this blood vessels, and if this patient has already has, say, we've said in the previous slide, he has already a cardiovascular disease where you can see the fatty deposit or plaque over here with the inflammation and the pro-inflammatory cytokine release, like a tumor necrosis factor, IL-3, IL-6, this will lead to rupturing of the plaque, which can activate a thrombosis and then will definitely lead to more oxygen requirement, and then it might increase the risk of cardiovascular MI or a heart failure or demand ischemia. And this is exactly the mechanism how a respiratory or a viral infection can triggers that inflammatory pathway, which can lead to a cardiovascular complications and then hospitalization and mortality. And so what are the numbers? We've said that the cardiovascular complications can occur in a patients of 18 years and above. They found the incidence of 14% to 22%. And the exacerbations or complications can be ranging from an MI, myocardial infarction, can be an arrhythmia, can be a heart failure. So what they did is in a study in the States, they looked at the hospitalization of a patients with RSV and compared it to the influenza. They found that the patients with the RSV has more incidence with 29% compared to 27% with patients with an influenza. And the 1-year survival rate following that hospitalizations with the RSV had poorer outcomes, specifically with patients who had an underlying cardiovascular disease, who had like a CHF, the chronic heart failure. And this is the graph to show you the incidence of hospitalization for an MI patient. You can find that there is actually good amount of cases, like around 6% incidence of patients who had an MI because of the influenza virus, and 3.5% because of the RSV, and other viruses around 2%. And this graph also from an weekly observed admission, you can see that the estimated excess MI admissions attributed to a virus was more in the RSV compared to the influenza in the influenza group. This is to look at the chronic heart disease and the associated hospitalization. And we basically here, we are focusing on a cardiovascular disease, which is the chronic heart failure. And in this graph, you can see they were comparing patients who had not have any chronic heart disease and compared to the patients who have a chronic heart failure in adult age 18 years old. And you can see there is definitely an increased association with hospitalization. Looking at patients even less than 65 years old, also against chronic heart failure has higher incidence. And with the patient 65 and above, they had more hospitalizations with RSV who had a chronic heart disease or chronic heart failure condition. This is to show you again how the survival rate with the patient who had a chronic heart failure. If you look over here to the right side, their survival rate for comparing patients who did not, in the black line, did not have chronic heart failure, compared to the patients who have a heart failure, but they never had any exacerbation, and a baseline patients with heart failure, baseline with an exacerbation, you can definitely see that the survival rate is declining, who had patients with the RSV. And in this table, the survival estimate at patients who had an RSV infection with a patient who did not have at the baseline heart failure, who had a heart failure at baseline with no exacerbation, with a baseline heart failure with exacerbation RSV, you can definitely see it's consistently declining from a 3-month to 6-month to 9-month and 12-month survival rate. So that basically will show you that a heart failure as a comorbidity, patients who will get an RSV will definitely have a high mortality and a less long-term or poor long-term survival rate. So in summary, the complications or the cardiovascular conditions, you can say that the RSV may cause cardiovascular complications in patients of older adults, including heart failure, AFib, myocardial infarction. And older adults with a heart failure and CAD are more at increased risk for complications of the disease. And the 1-year survival rates following hospitalizations with their RSV is poorer among adults with a heart failure or a heart failure exacerbation. So what is the diagnosis, management, and preventions of the RSV? So why we're talking about RSV, why it is really important for testing. Usually the usually in the clinic as in the outpatient or practice, we don't usually screen for an RSV as a routine testing for incidents. Usually we see the patients, we say it's a viral infection, we send them home. We don't usually do a testing for the RSV virus. But why it is really important? Why we're saying it's sometimes important to do the testing or do the routine testing for this kind of patients? First of all, it is really important because it enables us, or it gives us time for an isolation. So if your patient comes, especially older adult, and if he's infected and there is other or older, his wife, his young children, or any other older adult in the family, it is really important to make sure that the patient is isolated, make sure he's not in contact with anyone, so because it's a very contagious disease. Also, it gives us an informed clinical decision and to enable implementations of an early intervention, which may improve outcomes. Also, counseling to counsel the patients and their family about the prognosis, especially with that populations who have comorbidities like COPD and asthma, and to counsel them about if they're hospitalized or if there is a risk of hospitalization, how to take care of themselves and make sure that they don't get complications. Also, it is really important to diagnose it in a way that you would be able to make sure that to reduce the inappropriate use of antibiotics, specifically in the inpatient. Usually in older adults, in the inpatient units, when we take care of patients who we're suspecting a viral infection, we start giving them antibiotics, empiric antibiotics with 2 and 3 antibiotics. And this kind of testing for those patients will definitely give us the appropriate diagnosis where we'd be able to discontinue the antibiotics and make sure that he doesn't need it. So what is the diagnosis? We said that the symptoms of RSV infections are usually non-specific from other infections. So, and testing usually is needed to confirm the diagnosis. We have to do the testing to confirm the diagnosis, and usually this is not routinely done. And the management, currently there is no specific treatment available. It's mostly supportive. We give supportive care for those kind of patients. And the prevention currently, there is a vaccine that become available for the populations of adults 60 years and above. And previously, there was no actually any non-pharmaceutical infection prevention. And now with these vaccines, we have the preventions for these populations who are at higher risk of getting and protect themselves from against the RSV infection. So what is the vaccine? I'm just going to give you a brief summary about this vaccine, which is the GSK PRSV PrEP OA vaccine. And the profile of this vaccine, it's basically designed, it's a combinations of two systems. And it's designed to induce the robust humoral and cellular. So they're targeting the humoral and cellular to get the most benefit of that, most benefit and response to that vaccines in this population. And the combinations are the RSV prep antigen, and this antigen, which gonna boost the humoral immune response in the older adults. And there is an adjuvant system added to the antigen, which is going to boost that cellular immune system response and restore the CD4 T cells level in older adults. And that's going to give it the strength of the vaccine. To support this vaccine, definitely there was so many studies, and this is a efficacy study to see how is this vaccine came to the market, how it got approved, and why it's approved, and if, if the efficacy is good or not. And this is a randomized phase 3 placebo-controlled. It's a multi-country study. And it was looking also for the safety of a single and annual revaccination doses in a populations of 60 years and above. And if you're looking at this ongoing trial, what they did is they started with the 60 years and above. The populations were around 24,000 patients. They participated in the study. And it was two arms. So the first arms, they randomized the patients into the arm where they received the vaccine. And the other arm, which was the placebo arm, where they did not just they did just receive a placebo vaccine. No, not a vaccine. It's just a placebo. And then they looked at the season. So that was the first season of the vaccine. And that vaccine was given to look at the efficacy of the vaccine. And the primary endpoint for that is to look for the efficacy in the prevention of the RSV in adults 6 years and above in the first season. And the secondary endpoint is to look at the efficacy of that vaccine in the prevention of this population over 2 seasons. That means 2 years of the study. And in that, the second year of the study, what they did is they took the randomized group or arm, and they divided again into a second dose arm and a placebo one. And this third arm, or the second arm from the previous year, it continued with the same number of patients. And then they did multiple analysis checkpoint for the data after the first season and then the second season. So what are the summary of that study? So the efficacy of the study, they found that in the first season of the analysis, it found that there is a high consistent efficacy against the full spectrum of the RSV disease, regardless of the subtypes of the virus. And the efficacy was 82% for the RSV patients, and for a 94% prevention for severe RSV, and they found it's more more efficacy in a population who had one or more comorbidities for the RSV, and 93% it was actually more consistent with the older population. They were in the 70s years old. So one dose of the vaccine has provided the efficacy that we were looking at in any vaccine, to be honest. We look at a higher efficacy to make sure that this vaccine is work well in that population to prevent the disease. And in this vaccine has definitely demonstrated that even against any severe complications of the RSV disease, and even in the patients with underlying comorbidities. And the other results of that study, that the revaccination after 12 months, that's the second year, did not show to appear any additional efficacy benefit for an overall populations. And that means that the first dose of the vaccine was more efficient, and it doesn't need another vaccine in the second year to be given. And the safety for the vaccine, it showed that it's well tolerated, was acceptable safety profile like any other vaccines where you have some fever, some pain, site of injection, nothing really it's worrisome, and it's more reactions that it's mild to moderate intensity, and it was for a short-lived, a day or two, and it's gone like any other vaccines. And the reactogenicity and safety profile of a second vaccine were in line with the first dose, did not show any increase of the safety profile or concerns. How about co-administrances? We have some other vaccines. Currently, the study was done in co-administrations between the influenza and the RSV. It did show the co-administration was safe and without any evidence of a clinically meaningful any interface with respect to immunogenicity. There was no interactions or reduce the other immunogenicity for the other vaccine. So it was safe to co-administer with the influenza, and it was well tolerated and acceptable with the safety profile. So in conclusion, the available evidence from that study and the phase 3 trial that the administrations of that vaccine, the RSV PrEP 3 with the flu vaccine is safe. And that's it. Thank you so much.
Thank you so much, Dr. Reem, for these wonderful presentations that you have highlighted the disease as well as the specific groups who are at risk of having the complication of the disease, with special focus on congestive heart failure and COPDs, plus the vaccine, which is a really promising tool that we can protect our at-risk populations with this kind of safe, efficacious, tolerable vaccine. So before we go to the Q&As, I think we will go for the post-test. Okay, so I think I will share my screen. Okay. So now again, I would like you to scan the QR code, and we'll go again through the questions once again, and we'll see how we'll be answering these questions after going through the presentation.
دكتور أشرف عندنا نهاية البرزنتيشن في بركود ثاني، هذه قبل بعد
البرزنتيشن حقتي ولا
تبع الدكتور أشرف؟
اوكي.
So this is the one. Okay. So please, my apology. Just scan this code. This is the post-event question. So just scan it, and we'll go through it now in a minute. Okay. So we'll go. Okay, respiratory syncytial virus infections may occur in upper respiratory tract, lower respiratory tract, lower digestive tract, upper and lower respiratory tract. So please answer the questions. Okay. Any answers? So the correct answer will be upper and lower respiratory tract. So this is the correct answer, because RSV is not confined only to the upper and lower, and definitely not to the lower digestive tract. It's both upper and lower respiratory tract. The second question, all of the following groups are at increased risk of severe illnesses due to respiratory syncytial infection, except older adults, especially those aged 60 years or old, healthy teenagers, people with chronic heart or lung disease, immune-compromised people. So what is the answer? So the answer is except healthy teenagers. We have seen by Dr. Renim, she showed it elegantly that the spectrum, the two extremes of age, the infants and the adults, they are at risk, like teenagers and the mid-adulthood, they are not at risk at all. Okay, so true or false? After full recovery from RSV infections, most individuals cannot get infection. Is it true or false? So the correct answer is false. So even after full recovery, there is tendency to have a second infection, especially in those people at risk group. And then incidence rate ratio for RSV hospitalization in older adults with COPD is compared to the healthy individuals. Is it 2.3 to 3.6, 3.5 to 13.4, 3.6 to 6.5, 4 to 7.6? So the answer will be 3.5 to 13.4. This is the ratio, incidence ratio for hospitalization for those people who are elderly with chronic obstructive pulmonary disease. The next question is incidence rate ratio for RSV hospitalization in elderly patients with congestive heart failure compared to healthy. Is it 2.3 to 3.6, 3.5 to 13.4, 3.7 to 6.5, and 4 to 7.6? So the answer is D. So 4 to 7.6, and it has been shown in the presentations in one of the slides. So with this, we have answered all the questions, and I hope that these questions has been initiated your critical thinking about the RSVs in different risk populations, and at the same time, the pre-test and the post-test should make some kind of difference after going through the presentation of Dr. Redim. So now, ladies and gentlemen, I would like to open the floor now for the Q&A session. So Dr. Amin, I have a couple of questions by the audience. One of the things that is, it's a common sense that we are passing by a season where we have encountering a lot of upper respiratory tract infection. Some of it is influenza A and B, some of it COVID-19, and the other is RSV. So clinical-wise, if you are in primary care without any tools of diagnostic tools, so from the symptomatology point of view, how you can differentiate between these three different respiratory tract infections?
Good question, actually. I can't really differentiate clinically between of them. That's what I'm saying. You can say it's a viral infection like symptoms, and you can do supportive measures and send patients home. That's why I'm saying it's really important sometimes to do the testing to confirm the diagnosis of an RSV, so we'd be able to know which virus is it.
Okay. How about the RSVs in terms of RSV in pregnancy as a disease and the use of the vaccine in pregnancy? Is it safe?
So the population that the vaccine has approved for is 60 years and above. This population, none of them is pregnant. Nothing really yet that came out of studies saying that it's safe to be given to the pregnant woman.
Okay. So, all right. So you said, Dr. Ranim, that the RSV labs are not done in routinely in the outpatient clinics because of it's expensive, it's not feasible in some of the centers. So why we have to do this kind of lab test while the treatment is the same? So
yes, I understand that.
It's symptomatic treatment, I mean, just all what we do. So why we have to go for the lab investigations to identify the upper respiratory tract is because of the RSV?
Well, it's really important sometimes, especially I'm talking about older adults for the isolation. We don't only face older adults in the outpatient practice, we also have the inpatients. And this population, I can guarantee you that every single patient who had a viral infection, like a fever, you have some runny nose, or like maybe have some tachycardia, we would hammer them with 3 and 4 antibiotics. First of all, we can take off their antibiotics, and I mean, antibiotics exposure definitely is going to cause some drug resistance. So this is one of the things why it's really important to do the testing. Second of all is the isolation. Most of our older adults, they come to your clinic with a caregiver. Always like almost all of them, they have a caregiver who lives with them in the same room, taking care of them, taking them to the bathroom, taking them shopping, helping them with their activity of daily living. So it's really important to do the testing and say, oh, this is not this is something viral that you need to make sure that you isolate yourself so you would not infect, because it's a very contagious disease. The other third point that that I've mentioned already is the counseling. I mean, if I know that my patient is frail, and frailty, as itself means that the patient is frail، يعني وهن عنده هذيان he's more of a high يعني risk of high mortality and morbidity by as a يعني frail. فما بالك لما يجي له كمان infection تاني. I have to really counsel him and make sure that he take a good care of himself. He do the make sure that the supportive measures are there, making sure even if he gets hospitalized, to make sure that, because I know by fact, by studies, that this RSV can definitely impact his emotionally, functionally, their quality of life. So I have to prepare them and make sure if you get to the hospitalized, you have to make sure that you use the physical therapy, you have to be involved with the occupational therapy, you have to eat really good. It's counseling as how we look at the patient as a whole in geriatrics. So from my end, I think it's really important to do the testing for so many aspects, and these three reasons are why I think it is really important to do the testing.
Okay, thanks so much, Dr. Ranim. You mentioned in your presentation, this is one of the questions that came, you focus on the congestive heart failure and COPD that subject those people to, with the RSV, to have high mortality and long-term low survival rate. How about those with diabetes and chronic kidney disease and immunocompromised patients? Do they have the same subjectivity to high mortality and long-term low survival rate as well? Or there is some kind of difference?
No, actually, so the COPD, the studies did show a really high correlation between them, even the chronic heart disease, but that doesn't make the diabetes and other comorbidities or chronic diseases less than them. They're all really, if any patients, there was a study that it's in the presentation. If you can see that in that big study, even one comorbidities did show an increase of hospitalization rate, which included the chronic CKD, liver disease, patients with cancer, neurodegenerative diseases, and even autoimmune disease. So that means any chronic disease in the older adult will definitely make them at a higher risk of hospitalization.
Okay. One of the questions, can we use antiviral medications to treat RSV infections? Is it in
No,
the...
there is no evidence to use it. Usually, this is how we treat respiratory viral infections, is by supportive measures. We don't use the antiviral medication.
Yeah. Regarding the vaccine, Dr. Ranim, if the patient has RSV infections, how long we should wait to give him the vaccine?
As a second dose or a booster?
It's 2 doses, right? The first
it's a one-time dose. There is no need for there is no booster. And in the study of the efficacy of the vaccine, if you look, they looked at the first season, which means 1 year. And then they looked at the second season, which is 2 years. So it's a total of 2 years. And they gave two, in the first year, one vaccine, and the second year, the other. It's not a booster. It's a second, like the influenza, giving another vaccine every year. They did not see any changes in the immunogenicity and nothing. I mean, the efficacy did not change. Actually, they found that the efficacy continued to be in the second year the same. So there was no need for a booster, and there was no need up to 2 years to get another dose of the vaccine or another vaccine, RSV vaccine. The
question was RSV infection. After the recovery, how long we should wait? Shall we wait for 2 months? Like
I'm sorry, I did not get it.
Shingrix, for example, we wait for two
after the
2
symptoms.
months.
If you
After
no,
weeks,
after the
that's
symptoms, yeah, usually if after the symptoms, you would just give the patient the vaccine. After the infection period and patient improves, you can give it.
okay. Regarding the protections, how much is the protections, the percentage of the protections for the RSV in these
The
immune-compromised patients?
I would say immune compromised patient, there was no yet there is an ongoing studies for immune compromised. I mean, if you were to count the older adults as immune compromised because of the multiple comorbidities, I would say the studies have shown like around 94%. But in terms of patients with cancer, and there was an ongoing studies looking at them.
Thank you. There is a question regarding the vaccine hesitancy. You know, Dr. Alim, we have been passing through a very difficult transitions after the COVID-19 and the vaccines that we have encountered. There's also a lot of debate, a lot of hassles, and now there is a fatigue. There is a vaccine fatigue has been witnessed in our community. So, what are the measures that we can implement in order to spread the culture of commitment to have this vaccine, especially in those people with at risk?
والله this is a good topic يعني vaccine hesitancy أو طبعا الميديا and education, patient education is really important. يعني you have to have a good trust between the physician and the patient. So if he trusts his physician, he trusts his judgment, give him the right education, tell him what's the best for him. That definitely can make the patient more accepting for the vaccine. And definitely, يعني, as a strategy that I usually use in my clinic, especially for all adults, because we have multiple vaccines, and the flu is every year, and the COVID is almost every year, with the administrations of 2 vaccines, that would definitely help with older adults, making sure that they take the vaccine and they don't have that phobia of every single visit I come, I get a vaccine. It's only one-time shot and you're done.
Yes, you're right.
But co-administration definitely also helped in the vaccine hesitancy.
I think the strategy that we work on three different domains, for vaccine hesitancy and fatigue. One is the patient, so we try to educate the patient and the caregiver who are taking care of that particular patient, the sons, the daughters, and knowing that the protection that has been evaluated and proven to be secured by having these vaccinations to protect the health of the elderly patients, they will understand, they will get motivated. And community awareness as well. And the other thing which is very important for us is the physician themselves. It's another domain. We should not miss any opportunity where we have a patient at risk, elderly patients encountering a physician, regardless of the specialty, and leaving the hospitals or the primary care without having that vaccine. So this is a missed opportunity. So that's why we had tried to elevate the clinical inertia, that many of us reluctant to talk about vaccine in that very busy clinic because it's consumed times and so forth. And the third thing is the healthcare system. So now we have the national immunization programs for the adults, which has to be reinforced. We have the insurance companies that pay for the end user or the patient. They should be mandated to secure the financial coverage of the vaccine and the vaccine available in the primary care in the Ministry of Health and so forth. The multimedia and the social media, this kind of hassles that we encountered, we should defend these informations and clear it to be more appealing for people to understand exactly what are the information that they have to get it out of this. So it's a big topic, and in fact, it's a collaborative work, in fact. But we are in the primary care, we are encountering this very common because we are the first contact with patients, and we encounter a missed opportunity in reality, that we don't have to waste it. So I think we have covered almost all the questions. The last question, the last comment, Dr. Anim, if you can give a small advice, a brief advice to the primary care physician to just hold them responsible and to encourage them to take the opportunity to advise for the vaccine for the RSV. What would you like to say to them?
I would like to say, I'm going to copy you. Please take, honestly, to take every single opportunity to speak with the patient about healthcare maintenance and prevention. Prevention in older adults, it's the key component of taking care of an elderly, making sure that they're still at home in their community, functional, healthy, with a good quality of life. So prevention vaccine is the way to go for our population to stay healthy and at home.
Thank you so much. I think we were supposed to be joined by Dr. Mohammed Athinian, who is a preventive medicine specialist and part of the National API team. And he was supposed to talk to us about the recent introductions of the RSV vaccine and the recommendation by Ministry of Health. If you can highlight this, Dr. Amin, so how we position the RSV vaccine now in our adult national vaccination programs.
طبعا الحمد لله إنه the vaccine is approved, is currently in the almost all MOH primary healthcare centers, and it can be given, it's available, which is really really very nice, to be honest. الله يعطيهم ألف عافية. من ناحية يعني they had to take the opportunity really to use that available resources to give it to the patient. في جزء تاني سألتني هو دكتور أشرف اللي هو من ناحية التطعيمات، الجدول التطعيمات.
Yeah. Yes.
Still, I don't think it's in the
No.
national no registry. No, it's not. So if in the future it will be added, that would be a great thing to go. يعني طبعا هذه opportunity مرة رائعة إنها تكون عندنا في جدول التطعيمات لكبار السن.
هو الدكتور عبد الله عسيري وكيل وزارة الصحة المساعد للصحة الوقائية هي announced that وزارة الصحة أدرجت التطعيم، والحمد لله السعودية، المملكة العربية السعودية كانت خامس دولة تدرج اللقاح على مستوى العالم. فالحمد لله we are ahead of many countries globally, and our main intention is to save our community and our population at risk. And as you know, our national transformations, رؤية المملكة 2030, is built on three major components. One is مجتمع حيوي, and then اقتصاد مزدهر, and then وطن طموح. فبدأنا بمجتمع حيوي. كيف نحصل على المجتمع الحيوي هذا؟ إذا المجتمع بنقدم له كل الخدمات الوقائية حتى نعزز مفهوم الصحة ويتمتع المجتمع بتمام الصحة وكمال العافية حتى يزدهر اقتصاده وإنه ينطلق الوطن بإذن الله إلى أن يصبح وطن طموح على المستوى الدولي بإذن الله. We are investing in our human capital, which is the individual and الإنسان. فالحمد لله, this is a really privilege to be part of this wonderful country that implement this kind of concept. طيب, because we don't have any more questions, on behalf of all the attendees, Dr. Amin, I would like to thank you for your valuable time.
Thank you.
Your wonderful expertise, and the way you presented the presentation was remarkably attracting and engaging, and we learned from you a lot of ideas and a lot of information. So looking forward, inshallah, to have you more and more with us. And I would like to thank all the attendees who were more than 1,000 attendees today with us. And I hope what we have delivered today, we will change your mindset and engage you more towards looking into patient at risk in our clinical setup, whether it's a primary care or secondary care, and to try to deliver the opportunity of giving the safe and efficacious vaccine for the RSV. And I would like to thank my colleagues in the Saudi Society for Family and Community Medicine for having this kind of scientific activities going throughout the year to elevate our educational levels as physicians. And I would like to extend my thanks to the GSK company for giving us this opportunity to be together today. Another thanks goes to ملتقى الخبرات لتنظيم المعارض والمؤتمرات for the wonderful organizations of this event. With this, ladies and gentlemen, I would like to thank you again, and looking forward to have another session tomorrow, and the third one would be subsequently coming on the way. With this, I would like to thank you and wish you a very good night. Assalamu alaikum wa rahmatullahi wa barakatuh.